Next, I'd like to introduce Dr. David Arterburn. Dr. Arterburn is a general internist and a senior investigator at the Kaiser Permanente Washington Health Research Institute, an affiliate professor within the University of Washington's Department of Medicine. Let's give a warm welcome for Dr. Arterburn. Thank you, Dr. Arterburn.
Thank you, Dr. Butch. Really appreciate the opportunity to present. I want to thank the committee for that opportunity today. I'm going to be providing a health system and health services research perspective on the use of BMI to diagnose and treat obesity. Health services research is concerned with how we best organize, finance, and deliver high-quality healthcare. So I'm going to be talking about how we use BMI as a quality measure in healthcare, as well as its implications for the cost of obesity, implications for using BMI from an economic standpoint, and BMI alternatives. I conduct research in a primary federally funded research environment at Kaiser Permanente Washington Health Research Institute in Seattle. And Kaiser Permanente is a nonprofit integrated health insurance and care delivery system in the United States. Other than my employment for Kaiser Permanente, I have no conflicts of interest to disclose. My views and opinions expressed today don't necessarily represent the views and opinions of Kaiser Permanente. So I want to begin by discussing about this question of how good are U.S. healthcare systems at measuring BMI? And to answer that question, I'm going to turn to data from the National Committee for Quality Assurance, or NCQA, which is a nonprofit organization dedicated to improving healthcare quality in the United States. Back in 2007, 2008, I worked with Sarah Samsel and a committee of experts from NCQA to develop the Adult BMI Assessment, or ABA, performance measure, which assessed the percentage of U.S. adults that had an outpatient visit where a BMI was documented in the past 2 years. You can see here that when the ABA measure was launched in 2009, only about 40% of health plans and patients were getting a BMI assessed during the past 2 years. Fast forward to 2019, and more than 80% of commercial HMO patients and Medicaid HMO patients were having a BMI assessed. And that led actually in 2020 for NCQA to actually retire the ABA measure. And they cited a number of reasons why they were retiring the measure, including the fact that performance had nearly topped out in the Medicare population at 96%. The fact that BMI was automatically calculated in electronic medical records. They wanted to reduce the burden on health plans for reporting quality measures that were doing really well as ABA measure didn't seem to really set a high bar for obesity quality because it didn't address counseling or other types of follow-up. At the same time that the adult measure was being launched, a measure for children and adolescents was launched in 2009. And you can see that in 2009, about a third of children and adolescents 3 to 17 years had a BMI percentile in the medical record. More recent data from 2021, and this measure has not yet been retired, showed that more than 2/3 of children and adolescents have a BMI measure on the electronic medical record. Similar percentiles are found for the rates of counseling for nutrition and physical activity in children and adolescents. Now I want to transition away from measuring quality of BMI assessment in health plans to thinking about how does BMI relate to healthcare costs. And to answer that question, I'm going to go to the U.S. Medical Expenditure Panel Survey, or MEPS, which is a nationally representative survey in the United States every year. These data come from a paper by Ward and colleagues from Harvard, published in 2021, that used medical expenditure panel survey data from 2011 to 2016. The figure on the left shows the predicted expenditures or estimated expenditures and the total healthcare costs for adults at different BMI categories, with the lowest healthcare costs being associated with a BMI between 18.5 and 24.9, and healthcare costs increasing up with BMIs above that, particularly for BMI greater than or equal to 35 for both males and females. And you can see across all BMI categories that females had slightly higher costs than males. The right-hand panel, though, shows the relationship for children and adolescents. And you can see that there's very little relationship between BMI percentile in children and adolescents, or BMI Z-scores, and the total healthcare dollars up until you reach the point of a BMI greater than or equal to the 99th percentile, at which point there's a sharp increase in total healthcare costs. So how does this translate for adults into current healthcare spending? So this figure shows the total annual healthcare expenditures for U.S. adults based on estimates that I updated from Ward et al. Using the Bureau of Labor Statistics inflation calculator. So for a BMI between 30 and 34.9, adults with a BMI in this range have average total healthcare spending of about $7,300 per person. Whereas for a BMI over 35, that's $9,300 per person. When we compare that to the 18.5 to 24.9 BMI, we see that the costs are 26% higher for BMI over 30 and 43% higher for a BMI over 35. So how does this translate into a health system like Kaiser Permanente? The left-hand figure here shows the prevalence of different BMI categories in Kaiser Permanente, Washington in 2023. And you can see that 23.9% of adults had a BMI in the 30 to 34.9 range, and 17.3% of adults had a BMI over 35. We compare that with the percent of total healthcare costs that are associated with each of those BMI categories, which is shown as in the figure on the right, where a total of 50% of total healthcare costs are associated with 41% of the patients that have a BMI over 30. So with that background on healthcare spending, I want to begin to pay attention to what are the costs of alternative measures of adiposity. And this table lists various alternative measures of unhealthy or visceral adiposity, some of which have been discussed today, including anthropometrics, like waist circumference and the like, including the digital anthropometrics, which would cost nearly nothing or about zero per test. They're not entirely zero when measured in the clinical setting because we still have to train staff, and it does take some staff time to actually measure these, but they're as close to zero as we can get for a measure of visceral adiposity. And a hypothetical laboratory measure is the next one here on the list. I say hypothetical because we don't currently have a laboratory measure that fits well for this test or for this particular use of identifying visceral adiposity, but a typical laboratory measure might cost around about $100 per test. Whole body DEXA, while that's better measure of visceral adiposity, is about twice that cost, about $200 per test. And you can see CT of the abdomen and MRI, which are much better measures of visceral adiposity, are also much more expensive. So what would be the impact of implementing these alternative adiposity screening tools in a hypothetical health system similar in size to Kaiser Permanente with 12.6 million members in the United States? Even if we focus just on adults aged 20 years and older, and with those with a BMI between 30 and 34.9, that's 3 million adults within Kaiser Permanente with a BMI in that range. And even if we only assume 50% uptake or adherence to this new screening measure, the table shows the impact on costs for alternative screening scenarios. The third column shows the cost with annual screening in adults between BMI of 30 and 34.9. Again, anthropometrics, roughly zero, but it's not entirely zero. Laboratory measures, just $100 test per patient per year would result in $150 million in additional costs for screening. Whole body DEXA would be double that cost at $300 million per year. If we were to switch to, say, an every 5-year screening interval, the same way we do with cholesterol tests in healthy individuals, that would reduce the cost between $30 and $60 million per year. But over the 5-year period of time, it would still add up quite a bit. CT, abdomen, and MRI on an annual basis is more than $1 billion. Every 5 years is $250,000 or more. And keep in mind that if we were to push for, say, a 100% adherence to this new test, we would double all these estimates of screening costs here. Also, if we wanted to implement this test for people with a BMI between 25 and 29.9, that population is actually larger, and we would increase our screening costs by 125%. Before you conclude that I'm clearly advocating for the use of waist circumference, I want to acknowledge that there are a number of barriers to using waist circumference in clinical practice, primarily coming from providers. And there is a number of qualitative studies that show that providers feel this is quite difficult and can be uncomfortable for patients. And there's perceived barriers of time, provider discomfort, beliefs about patient discomfort that strongly influence the use of waist circumference, why it's rarely used in clinical practice today. So next, I want to transition from measures of alternative measures to thinking about the implications of BMI currently for the cost of obesity treatment. And I'm going to focus in on obesity treatment guidelines and the use of BMI in those guidelines. Currently in our treatment guidelines, we recommend comprehensive lifestyle intervention for people with a BMI over 30 or those with a BMI over 25 with obesity-related comorbidities. And as we've seen today, that can be a very large list of comorbidities. And what the figure on the right shows for U.S. adults, what proportion of U.S. adults would be recommended comprehensive lifestyle intervention based on these interventions. And based on the number of comorbidities that are associated with obesity, as many as 65% of U.S. adults may be eligible for comprehensive lifestyle intervention. If we add in obesity pharmacotherapy to this list, we see that those are recommended for people with a BMI over 30 or BMI over 27 with comorbidities. That can be up to 50 to 55% of adults currently, and they would be eligible for pharmacotherapy with lifestyle intervention. Metabolic surgery, the American Society of Metabolic and Bariatric Surgery recently updated their guidelines recommending bariatric surgery for BMI over 35, regardless of the presence or absence of severity of comorbidities. That's 17% of US adults. Further, metabolic surgery should be considered for the individuals with a BMI between 30 and 34.9 if they have already metabolic disease, which could be up to 29% of adults. Furthermore, as we talked about earlier in the day, the Asian population, the American Society of Metabolic Surgery recognizes that BMI should be adjusted to 27.5 to recognize their increased risk at a lower BMI. And that further increases the proportion of adults that may be eligible for surgery to upwards of 30% of US adults. So these treatment guidelines have big implications for the cost of care in the United States. This table just shows 3 different tiers of estimated costs of obesity treatment. The first tier being intensive lifestyle intervention, phentermine and phentermine topiramate, or Qsymia, which range in cost per person per year from $60 to about $1,800, depending on the treatment that you're choosing. The second tier are these newer drugs, semaglutide and the proposed tirzepatide, which would cost between $13,000 and $18,000 per year. Sleeve gastrectomy and gastric bypass cost between $15,000 and $28,000, depending on who's paying, if it's Medicare versus a commercial insurer. So as we think about these different costs and the prevalence of these conditions, let's take a look again at a hypothetical health system that's similar in size to Kaiser Permanente, with 4.2 million adults with a BMI over 30 that are eligible for lifestyle intervention and pharmacotherapy, and 1.2 million adults with a BMI over 35 who are also potentially eligible for metabolic and bariatric surgery. Even if we were only to implement this such that we'd increase the number of eligible patients that were taking the treatment by 5%, this table shows the cost impact of increasing those treatments by 5% in our Kaiser Permanente population. Lifestyle intervention, phentermine and phentermine topiramate, range from $12.6 million to $250 million for 1 year of additional treatment for 5% of the eligible population within Kaiser Permanente. For semaglutide and tirzepatide, the cost is about $3 billion for 5% of the eligible population to receive that treatment. For sleeve gastrectomy and gastric bypass, the cost is between $1.6 and $1.7 billion at the commercial price. And so you see that cost for metabolic surgery is lower than the cost for semaglutide and tirzepatide. That's in part because the eligible population is smaller, but it's also because it's a one-time upfront cost for the most part, whereas for semaglutide and tirzepatide, these would be ongoing annual costs for chronic disease management. Let's also translate this to the Medicare level, and these data come from Baig and colleagues from Vanderbilt, recently published in the New England Journal, where they took a look at the impact of prescribing phentermine topiramate semaglutide for Medicare Part D spending. Medicare Part D provides prescription drug coverage to 47 million adults, mostly over the age of 65. This table shows that in the red bar, if 5% of adults with obesity in Medicare Part D were to receive a prescription for phentermine topiramate, that would cost $659 million. If 5% of adults in Medicare Part D receive semaglutide, that would cost $13 billion, which is 9% of total Medicare Part D spending in the current year. 50% uptake of semaglutide, which is not shown in the table, would actually cost $133 billion, which would fully exceed the current Part D budget, which is currently only $119 billion in 2023. So my conclusions are these: that healthcare systems really do a good job of capturing BMI currently, but there is clearly a large heterogeneity in adiposity-related risk, particularly for patients with a BMI less than 35. So from a practical population health standpoint, instead of continuing to broaden our obesity treatment criteria and treating more people with uncertain benefit, we clearly need to focus and better focus our criteria on those that are most likely to benefit. That is, we need to be narrowing our criteria. Additional adiposity screening measures are really needed to help identify patients who are at the highest risk of adiposity-related complications and those that are most likely to benefit from weight loss. However, these additional adiposity measures are likely to be expensive and difficult to implement, including waist circumference. And it probably won't help to better identify people at risk if we can't also afford to offer them treatment. And even a 5% increase in treatment carries substantial cost to our healthcare systems. And I want to leave you with a few unanswered questions from my perspective. One, if we're going to be proposing additional screening tests above and beyond BMI, do we have strong evidence that these tests identify people who are at higher risk of adiposity-related disease? How acceptable are these tests to patients and providers? How effective are we at implementing these tests, and how much do they cost? Finally, will we need new studies of lifestyle, pharmacotherapy, and surgery to demonstrate the efficacy, safety, and cost effectiveness of these treatments in these new subpopulations? And my answer to that final question is yes. So I look forward to continued conversation about this. I really appreciate the opportunity to present today, and I look forward to conducting research in this area along with colleagues in the field. Thank you for your time.